Hello and welcome to HealthTech Hour on UK Health Radio, the world's #1 talk health radio. My name is Steve Roost, and each week we bring you the best news, views and interviews with the CEOs, founders and clinicians who are changing the face of healthcare in the UK and beyond. I am a CEO and founder of a health tech company myself, and I am passionate about the people and companies who are changing the world. There is a lot to get through on today's show, so I'm going to start off by letting everybody know that the UK Health Radio Awards are now live and open for voting on ukhealthradio.com. If you have a favorite health product or a favorite health tech professional, go to ukhealthradio.com, click on the awards tab and vote for your favorite from the shortlist that are in each category. So all of the people and brands there have been selected by the presenters on the station as people who have made a huge impact in people's lives over the last 12 months. So yes, if you want to get your vote in, go to ukhealthradio.com now, and the results will be announced in August. Then, as always, I'd like to remind everyone to follow the show on the socials. It's at HealthTech Hour, and follow the station. It's at UK Health Radio, just to stay on top of all of the great content that's coming up on the show. So that's all of the admin out the way. Let's actually start the show. So today's show sees us return to an area that's personally close to my heart, because it's an area where our company PocDoc is active, and that's community-based remote monitoring and diagnosis. So, you know, that's quite a mouthful, but in short, it's the ability to deliver clinical level assessment of key health markers in the home or in the community or in care homes, effectively anywhere outside of the GP surgery or hospital, and to allow clinicians, doctors, to care for people remotely. Obviously, the need for remote solutions has been accelerated by the pandemic, but Dr Elina Naydenova, who is CEO and founder of Feebris, that's Feebris, were already making waves in this space before then. Feebris is one of the leaders in community remote monitoring. It's being used extensively throughout the NHS. They've won numerous awards for their technology and their approach. Their system, the Feebris system, allows someone to perform a full health checkup on themselves or someone else, including pulse, breathing rate, blood pressure, and O2, blood oximeter. And for those results to be shared in real time with clinicians, and for those clinicians to determine in real time if action is needed. Feebris are also an alumni on the NHS Digital Accelerator like PocDoc, and they've received the Children's Award for their work in helping children in India get access to healthcare. So it's a pleasure to get Elina on the show. Elina, how are you? Welcome to the show.
Good. Thank you so much for having me. It's a pleasure to join you.
Good. Well, look, as everyone that comes on the show, I kind of ask them, what's it been like over the last 13 or 14 months? What's the mood in the camp right now? What's kind of going on the ground at Feebris?
Yeah, it's a very good question. It's been mad. I think most people would probably say that, especially if you work in the healthcare space. I mean, we're not healthcare providers. I can't even imagine what that's been, for the frontline workers. But on our end, we explicitly focused on care homes and providing our technology in care and nursing homes across the country, and working very closely with the NHS and social care to really deliver a very transformed model for managing the health of elderly people. So it's been non-stop, I guess, mixed emotions of a lot of hard work, a lot of gratification from being able to support our NHS partners, but also, a lot of struggle of trying to find the right ways of transforming healthcare.
Okay, yeah, and we can go into it because I know that you guys have obviously made huge strides over the last 13 to 14 months, but I don't want to underplay the fact that you guys were already doing this, before the pandemic came around. You were sort of visionaries in the remote monitoring space, which we'll get into. But I think it's kind of easy to sort of just assume that people have jumped on the bandwagon, but you were one of the early people to start pushing this type of technology. So as regular listeners know, the show is split into 3 parts. The first part is an origins part, really about how you came to be, on your journey to changing the world of health tech. The middle part is all around all of the great stuff that you're doing right now in the world of health tech at Feebris. And then if we get to it, if we have enough time, it's a discussion about what the future holds and whether there's any other topics of the day that we want to talk about. So let's kick off. So Elina, you were into health tech at a relatively early age. I think you studied biomedical engineering at university. So was it always an interest? Did you always know that you would end up on this pathway, or how did you sort of start?
Yeah, I was always fascinated by the opportunity to kind of bridge the innovation that technology can bring about and the real world impact that you can have in healthcare. So that's why I trained in biomedical engineering. And initially I was working within kind of the imaging space, developing machine learning or AI algorithms for personalizing therapy in that space. But I always had a fascination with population health and global health in particular. So that took me to the World Health Organization and the medical device group there, where I was very fortunate to be given a project that I knew nothing about called childhood pneumonia.
Okay.
And at the time, I hadn't realized that it's the #1 killer of children under 5.
Pneumonia is?
Pneumonia is, yeah. It actually kills more than HIV, malaria, and tuberculosis combined.
In the under 5s?
In the under 5s.
Wow, that's incredible.
It is absolutely shocking. It's still shocking today. It's just not, it's not the thing you hear on the news on a daily basis. And back when I was doing this work, it was responsible for nearly 1 million children's deaths every year.
Oh, wow, that's
which
really
is
high.
A very, very tragic statistic. But also for me, it became a first-hand experience because I was also very fortunate to do a lot of field work in India in urban slums and really see what it means for a mother to have a very sick child and not have the access to healthcare to actually be able to intervene early and turn what's a treatable disease into kind of a prevented death. So yeah, for me, that was kind of quite transformational for my journey. And I realized that, it's one disease, but it's very emblematic for what's really kind of wrong in our healthcare delivery these days, or what's missing in our healthcare delivery these days, the ability to detect disease early on and avoid a lot of suffering and mortality.
Okay. And so when you kind of started off on the biomedical course, because it's one of those course titles that I'm sure most people may have heard of it, but they might not necessarily know what's actually involved in it. So why did you end up doing biomedical engineering and not something else in the healthcare space?
Yeah, it's a good question. I had a very kind of mixed educational experience. I actually trained in maths and physics and had the opportunity to work on various kind of biomedical engineering projects with, at the time, was more around designing hardware and hardware techniques for improving various diagnostic problems. And over the years, that then kind of evolved and matured into how can we use advancements such as machine learning into delivering better healthcare. So the reason why I ended up in this space is because I always felt like an innovator. I always was fascinated by what is the next best way of solving this problem, both studying the problem, but also coming up with various opportunities to address it.
Okay. And after your work with the WHO, did you stay in NGOs in the charity space, or what happened after that?
So yeah, I continued working on various kind of consulting projects on the innovation front, and a lot of them associated with NGOs. But also I moved back to Oxford and did a PhD specifically focusing on designing machine learning for healthcare innovation. And I really wanted to prove to myself that we can use machine learning to diagnose pneumonia in community settings.
Okay.
So I spent 4 or 5 years in academia, really digging deep into how do we do this in practice, how do we run the clinical studies to validate the algorithms, how do we develop the algorithms themselves, et cetera, et cetera.
And why were you so interested? I'm asking generalized, but why were you so interested or convinced that machine learning could help better diagnose childhood pneumonia?
It's a very good question. For 2 reasons. One is the complexity of the disease means that there isn't a single device you can give to a patient or to a clinical worker to diagnose it.
Is there out of interest, is there a diagnostic test, or is it a pathology lab only route?
So the gold standard diagnosis would be an X-ray and a blood test.
Oh, really? Okay.
Which obviously requires sophisticated hospital infrastructure that's inaccessible for a lot of people.
Is it a blood test and an X-ray, or can you do one or the other? It's an and.
Ideally, it's both.
Wow.
Ideally, it's both.
That's a big bar. That's a high bar.
It's a very high bar, but also the journey to that bar involves a well-trained primary care physician. It could involve a pulmonologist that uses a stethoscope to listen to the chest and identify various sounds. So a multitude of very highly trained professionals and very advanced technology to reach a diagnosis.
Okay.
Which in low resource settings is close to impossible because you simply don't have access to all these people and all these technologies. And the other thing that's always been fascinating to me is the need to rethink delivery models, especially in emerging markets. So specifically at the time I was working in India, and there was, and still is, a very kind of fast growing workforce of community healthcare workers. Okay. So people that have minimal training, formal training, that is an education, but who are very well versed in conducting kind of community processes like documenting vaccination levels or delivering education to prospective mothers, etc., etc. And that workforce can be very, very powerful. They see these patients on a daily basis, but currently have very limited tools of what they can actually use to deliver any sort of healthcare intervention or interaction. So for me, it was basically a mixture of the two, thinking about if there is anything that I would like machine learning and AI to achieve, it is democratize access to healthcare and fill in the current gaps in delivery, which stem from the fact that we don't have enough doctors. Globally, I think we're missing 4.3 million. So it's virtually impossible for everyone to get access to healthcare when they need it. So what is the gap that we can fill in with machine learning, and pneumonia being the first problem that really fascinated me.
And back then, when you came back from your fieldwork in India and you were getting back into your PhD or starting the PhD with this kind of solving this problem in mind, how did you kind of envisage that it would be solved? Because machine learning and AI is kind of the terms that get thrown around quite a bit, obviously. But how did you envisage that would be kind of, I guess, implemented? Did you have a vision, or was it very much an open book and you wanted to explore different avenues?
Yeah, I guess that was kind of generation one of my journey, or volume one of my journey. So at the time I was very focused on technically what's possible, what's feasible. I guess that's where you get to explore in academia and in kind of research and innovation. Volume two then took me into entrepreneurship and kind of thinking much larger than the specific disease, and focusing on how can we realistically structure new workforce models around these types of technologies, and what do the technologies need to look like to really augment existing kind of workforce models that we have either in social care or in healthcare, to really power kind of a more precise and early detection of conditions.
Okay, and so was that the kind of start of your transition, as you said, from academia to entrepreneurship? So what motivated you to move? Because I have a question on my show script, which is, lots of people just stay in academia. I mean, that's quite a common pathway. So was there an epiphany, or was it just a natural progression for you to want to look into doing this entrepreneurially, or what happened?
Yeah, I think this one is more of a byproduct of kind of personality. For me, it was intellectually very interesting doing the research and publishing papers on it, but the thing that matters to me specifically is, does it make a difference to anyone's life today, immediately, as soon as possible? And equally, not to discredit, I think it's equally very important for people to stay in academia and continue kind of developing very cutting edge research and changing scientifically what's possible. But my personal motivations were really always revolving around people's lives and kind of how I can contribute to that immediately.
Making a direct impact.
Yeah.
Okay. And so what did that kind of first steps into entrepreneurship, or, taking everything you learned and creating a company or an entity, was that what became Feebris, or was there something before Feebris?
No, that's what became Feebris eventually. I mean, it took a while, as you've probably experienced. I'd love to hear your journey into getting a company off the ground, but specifically like the time when you are transitioning between kind of self-made startup into a funded company is quite tricky. So that took for us probably about a year before we were able to raise a seed round.
Okay.
And then that was probably the kind of the scrappiest inception stage that I can remember. A lot of kind of trial and error and learning different ways of communicating to investors. Also thinking about how you leverage the tiny amount of funding that you can kind of come by through grants, etc., to prototype something and show feasibility, etc., before you can attract more sizable funds to actually grow what you're imagining and dreaming of.
Yeah. And so when you was Feebris always in the remote monitoring and diagnosis space from the beginning? Was that always the vision, and how sort of true has it remained to that vision?
I would say we're not actually, I don't describe us as a remote monitoring platform or solution. We can facilitate remote monitoring activities, but fundamentally what we set out to do and are focused on doing is unlocking the early detection or the early examination that then leads to early detection in a community setting, which is very different from kind of the regular measurement of certain parameters that clinicians can kind of track remotely. So for us, the fundamentals behind our technology and the kind of the mission that we have is how can we create the most meaningful first interaction a patient can have with the health system in the community, so that the trajectory they follow from then onwards is one of recovery rather than one of further complication and exacerbation that eventually leads to hospitalization.
Okay, I think we're gonna. I'm sorry, I've got a frog in my throat. I think we're gonna have a commercial break now, because not just because I can't talk, but because the content on the station is extremely high quality, and we have some wonderful commercial partners that support us in doing so. So we'll be back after a short commercial break. Okay, hi, welcome back. Sorry about that interruption, but we're right back with Elina from Feebris. So before the break, we were just talking about how you would define yourselves as an early detection company, or a company that aids in early detection and ensuring that the first contact that someone in the community has with a clinician or service is meaningful. And so why is, just for the benefit of everyone listening, why do you believe that early detection is so critical?
So if you look at kind of the current state of affairs across the globe, I mean, health systems obviously vary, and some are dealing better than others with the burdens they face, but universally we face one kind of universal problem, which is we're missing 4.3 million doctors. What that then leads to is a lot of downstream costs. So if you can't see your GP early enough before your pneumonia, picking back the example we discussed a few minutes ago, before your pneumonia is mild, if you can't see your GP on time, that leads to an exacerbation that then inevitably ends up resulting in a hospitalization. And the difference in treating that early condition in the community versus the hospital is one of cost. Obviously, it's much more expensive if you're doing in a hospital setting. But for certain patient groups, it's also one it's also a difference in survival chances. So specifically the young children under 5 and also the elderly people. So for those reasons, it's incredibly important for us to also avoiding a lot of deaths. So the statistics are 15 million avoidable deaths that can be saved from this early detection every year across the globe, and also $1.7 trillion
Wow.
is avoidable.
And is that across all diseases?
We should have managed in the community or in primary care that
Okay.
if undetected early enough, lead to a lot of hospitalizations. So pneumonia falls in that bracket, but it's also COPD, asthma, heart failure, etc., etc.
Okay. And how does Feebris help with that, in detail?
So for us, the problem that's kind of been a fascination and what we focused on is what would it take to enable a non-clinical worker, such as a carer working in a care home, to be able to conduct a clinical grade examination in the community and triage the concern that that patient might be having into the most appropriate clinical channel.
Right.
And the reason why that's important is kind of twofold. One is we're able to task shift a lot of burden away from primary care. So if the carer, hypothetically, if the carer was able to do as good of a job as a GP doing the examination in their practice, then you can save the GP half of the 10 minutes that they have to spend with the patient.
Yeah.
And also very importantly, you can allow them to focus on what they do best, which is caring for the patient and making the very kind of high risk decisions, which is diagnosis and treatment. And also the other benefit is if they then have the decision, if the carer has the decision support on what is the most appropriate channel for this patient, you avoid unnecessary calls to 999, 111, or even the GP that can be dealt with through a kind of lower level, less expensive channel.
Okay. Sorry, go on. I interrupted you.
So that's effectively kind of what we focused on. And what we do is we've developed a platform which includes a mobile application as well as a number of off-the-shelf sensors, which we kind of sell and ship as a kit. And the care home can use them to conduct regular checkups or examinations with their residents, which then leads to a recommendation of how they should deal with the condition or the problem they've identified. We then help GPs manage these populations remotely and really focus on the cases that need their attention and can kind of direct their attention and focus towards the specific problems that these people are experiencing.
Okay. I think it's fascinating. Obviously, I mean, look, what we do at PocDoc is it's not the same, but it's in the same, we have the same passion and the same, the same sort of view about care in the community and moving stuff out of GP surgeries, out of a clinical setting, early detection, early diagnosis. So, this is definitely in our ballpark for sure. But I think what's really interesting, or one of the things I'd like to get under the skin of, is what was happening before Feebris to do this, if anything. Like what was the view about what you're doing?
Yeah, it's a very good question. So there are a couple of kind of generations of solutions that have already been attempted in this space. There is kind of, well, the very basic that it still remains kind of the status quo in most settings is there's nothing. So the carer would see the elderly person being unwell and they would phone the GP, and hundreds of GPs would tell us about the dreaded call of Mrs. Jones is not well today. Can you give me some direction of what she's experiencing? And the carer would say, I can't really tell you. She just looks pale and she's really tired. So very kind of non-indicative markers of disease that are obviously insufficient to make a diagnosis. And that's obviously stressful in the best of times. It's even more stressful during the pandemic when obviously the thing that people are worrying the most about is it COVID, or is it also an exacerbation of yet another condition that I can't manage because I can't physically go and see this person.
Yeah.
So that's was and in a lot of settings still is the kind of the status quo. There is then a generation of paper-based systems where people would be given some tools to measure some basic parameters like blood pressure or temperature, and then record what they've measured on paper and try and communicate that over the phone.
Okay.
And then there is also a generation of what I would call digitization of that process. So software that's able to, rather than typing on a piece of paper, have you type it into a box on
like a
on
data
phone.
collection app.
Exactly, like a data collection app, which is definitely moving us kind of further away from there being absolutely nothing in these settings. But the challenge that this has consistently seen, and also the conversation we should be having very honestly about as a community about remote monitoring, is there have been barriers to scale that are infrastructural, but also there have been barriers to scale because of the reliability of a lot of these technologies.
Okay.
Someone being able to take a measurement and then type in a number very often leads to a lot of error, which is
Human
perfectly
error.
natural. Exactly.
Yep.
Human error. It happens even in hospitals. I mean, if you look at the literature, a nurse in A&E is between 7 and 14%, or rather carries 7 to 14% error in the collection of vital signs. This is obviously a highly trained professional. We can't expect carers or patients themselves to be anywhere more accurate than that in a community setting. So for us, we kind of see ourselves as students of all that history, and what we have focused on is how can we design an AI-guided capture system that mitigates that error and eliminates basically the fear and disgruntlement that the clinical community feels when they're bombarded with all of this unreliable data.
Yeah, and so the issue that one of the issues you're solving, which I think I completely agree with, is the risk of human error in collecting results. Whether they're a trained professional, whether they're not a trained professional. But if they're not a trained professional or clinical professional, then it's even more important, particularly if they're under stress or it's a complicated situation. And so why did you kind of land on AI to solve that? Or how does Feebris solve that issue?
So we actually worked with partners on a kind of large scale, robust evaluation of what is the return on investment that we can expect from various remote monitoring setups, and kind of sliding a scale between totally manual through the connected devices, and then if we had various levels of decision support that minimize the human error, as you say. And what we saw is that to cross the chasm between negative return on investment and positive return on investment, we need at the very, very minimum have connected devices so that we eliminate the need for, or rather eliminate the risk from transcription errors, but also start diluting a lot of manual process like respiratory rate, for example, one of the most important vital signs that's still to date classically manually counted, where ideally a trained professional would watch the person's chest fall multiple times within 60 seconds and count how many times that happens. Obviously, that leads to a lot of error that then gets extrapolated into false diagnosis. So for us, it was simply impossible to address this multitude of challenges that emerge when you have complex technologies in community settings, unless you can have AI compensating for various levels of automation as well as decision support.
Okay, cool. And how have you sort of gone about, where does the issue lie in versus decision support or versus sort of that compensation aspect to it, trying to even out the variation?
Yeah, maybe just to give a few practical examples, which by the way are kind of even more pronounced in care homes, as you're saying, they're very stressful settings, particularly over the last 14 months. So what would typically happen is, for example, they would have to take a pulse oximeter reading, which for a lot of people sounds trivial. You can buy a pulse oximeter from the pharmacy and put it on your finger and it will give you 2 numbers. The problem is So first of all, a lot of the pulse oximeters you can buy are not medical devices, so shouldn't be trusted to make diagnostic decisions. They're not. They might be CE marked electronically, meaning they're safe for use. Doesn't mean they're CE marked as a medical device. And your doctors.
How can a pulse oximeter not be a medical device?
Well, the same way Fitbit can give you a heart rate that's not actually meant for diagnosis, but for wellness interpretation.
Yeah, do you know what though? Like, I don't buy a Fitbit to measure my heart rate, but I do buy a pulse oximeter to measure my heart rate. You know, that strikes me as a bit of a loophole there. But anyway.
Yeah, it's definitely that. But let's assume that we bought a pulse oximeter that is a diagnostic device and you can use it.
Yeah.
Then a number of challenges emerge. So you're working with a population group that, for example, often will have dementia. It would get really stressed about, why are you putting this thing on my finger now? Which would introduce a lot of motion. That motion leads to pollution of the sensor or introduces noise into the sensor, which could still generate a number, but that number is false.
Okay.
The carer obviously doesn't have the clinical judgment to execute to know, is this a realistic number that's perfectly normal for this type of patient or not? Another thing that would happen is elderly people often have poor circulation, so their hands will be cold. If you're in a clinical setting like a hospital, the clinician would obviously know to rub their hands together so that they warm up and increases the circulation. Again, a carer obviously wouldn't know to always think about these externalities. And there is a whole number of other things that come into play. So what we do with our technology is we're able to profile artifacts within the signals that we capture from these sensors and say, this is, let's say, you're putting the digital stethoscope in the wrong place because I can't hear any breathing, or the pulse oximeter indicates that this person has really poor circulation, so please advise them to rub their hands together, etc., etc. So in real time, we're able to basically correct behavior to make sure that by the time we've conducted the checkup, by the end of the 10 minutes, we have reliable data that then, when passed on to a clinician, gives them the confidence that whatever they're seeing is what they would have measured and can make diagnostic decisions on.
Because without that feedback process, you risk just collecting junk data, which will either lead to no diagnosis and a frustrated GP, or the wrong diagnosis, whichever way.
Yeah.
Okay, that makes a lot of sense.
And this is exactly what I meant when I was talking about negative return on investment.
Right.
If you're passing on bad data onto a clinician, at best you're wasting their time. At worst, you're introducing clinical risk into the process that then leads to further exacerbations and further burden for the health system. And in combination, this amounts to much more money wasted than saved from putting these technologies in community settings.
Yeah, no, I think that makes total sense. And so could you walk us through, I don't know, from a carer's perspective, or who is the main user of your technology? A carer?
It's a carer,
What do they do? They get the box and then what happens, so to speak? I mean, I'm being a bit basic, but...
Yeah. So they get the box and it's plug and play. So they'll find a phone that has a preloaded Feebris application, as well as a number of sensors. We'll conduct training with them. So we have digital training that they can use themselves, but we also are quite invested in kind of change management. So we offer support and a consultation that kind of talks them through when should I be doing the checkups, etc., and validates that they're well trained in conducting them. So once they've been through the training, what they do is they will start the checkup with our mobile app. It would first very much resemble what happens when you go to the GP, where they ask you a series of questions to identify what are kind of the most likely directions that this situation is going into. And then on that basis, we would decide what types of measurements we need to capture next. So to give you an example, if you report a respiratory symptom at the start, let's say a cough or loss of smell and taste, which is indicative of COVID, as we all know, then we would activate a more specialist device like the digital stethoscope. So then in the second stage of the checkup or the examination, the carer will go through step by step taking these various measurements. And at each stage, as we discussed, they will receive real-time feedback on the quality of the signal that they've captured.
Okay. And
so
sorry, go on.
At the end of the 10 minutes, they have kind of a structured summary of everything they've recorded, the risks that have been identified across all the measurements and the self-reported symptoms, and an overall evaluation of who should you be passing this on to. Is it the GP, or should you be phoning 999 straight away if it's a very urgent case?
And what's the full range of sensors that are included in the Feebris service?
So at the moment, we have all the conventional things that you would use in a kind of generalist exam, so a thermometer, blood pressure cuff. We also have a pulse oximeter and a digital stethoscope that feed into the more respiratory examinations, and we're constantly onboarding new sensors to provide a kind of a one-stop shop for an examination.
Okay, and the app itself, effectively, after going through the triage process, the symptom checker, it will tell the carer what devices to use. It will guide them through that.
Exactly. Yeah.
Okay, great. Well, we have to do another commercial break now, but we'll be back in a couple of minutes just to continue on our chat, because I think this is absolutely fascinating. So I've got a whole bunch more questions. Okay, hi, we're back. So carrying on from what we were just talking about, I know that Feebris, you mentioned it a couple of times, Feebris obviously has had a pretty, busy 12 to 13 months previously. And so at what point did you realize when the pandemic was starting that there were kind of major changes for your business sort of underway, or under, at what point did you start thinking, okay, this isn't just business as usual?
It's a very good question. So before the pandemic, we were mostly working in living care, private living care.
Okay.
Where you have, patients that have very advanced needs and they have a carer living with them 24/7. So there we were basically helping them identify exacerbations early on, so that they can prevent kind of step change into the person's condition. We also had large-scale deployments in India, specifically working with children. And there we were getting to a stage of really thinking, how do we slot this technology into community delivery in a way that almost creates a primary care model that doesn't exist in a lot of low resource communities. And what happened, as we all well remember, with the first lockdown, is all conventional healthcare delivery, particularly in primary care, ceased to exist. So we had to think about new models that hopefully uphold the same kind of standards of quality of care that we aspire to, especially in the UK. And we were very fortunate to win TechForce 19, which is a competition that NHS set up with partners to really identify innovation that can bridge that gap, particularly in kind of high-risk communities that were most affected by the pandemic. So for us, that was kind of the inflection point. And that's the thing that accelerated our work in deployments across care homes. We were also very fortunate to have exceptional partners, Care City and the whole team of BHR CCG. They were very kind of proactively thinking about what is the level of transformation that we need to deliver in these communities to keep the kind of the service of healthcare that we are committed to, but also moving forward to have a scalable model of delivery.
Okay. And what was it, were you being asked to deliver Feebris to new groups, or were you being asked to develop or adapt Feebris to do certain things that it hadn't really done before, or you hadn't done before, or a bit of both?
A bit of both. I think anyone working in this space, you probably say the same, knows that you have a kind of a certain level of product that meets the market where it is today. But particularly during a transformational time like what we experienced over the last 14 months, the market was constantly evolving.
That is
so
true.
the needs that we kept kind of seeing emerge from the community were really transformational for us as a company as well. And we were trying to keep responding to them and evolving the product alongside the health system.
And before the pandemic, I know you mentioned it, touched on it. You mentioned that there were some obstacles to scaling in this space and things like that. What were those obstacles, and did they change as a result of the pandemic? Have they been removed, or have they just been replaced by something else, or like what do you think?
Yeah, I think it's probably a little bit too early to say, but what we've seen is, so prior to the pandemic, we had really interesting conversations, and people were always very receptive to what we do as the future of healthcare.
Mm-hmm.
But we were always met with, is this really, really urgent right now?
Okay.
Or can we postpone it for the next couple of years?
Right.
And what the pandemic did specifically for our space is that it accelerated the realization that we can't keep postponing it. It was urgent before, and the avoidable deaths numbers that I was quoting and the staggering amount of money that we're losing due to the lack of kind of timely detection of disease was still there. They were kind of hidden. It wasn't as obvious as the pandemic made it. What that's done for us is the argument is much easier. We no longer have to kind of rationalize why do we need to have early detection of conditions in community settings, and why is the future of medicine virtual. That's kind of a given these days.
Yeah, that's kind of, I think that discussion's been sort of
it's been wrapped. But I'm curious whether you've had the same experience, because obviously different companies have kind of experienced this differently.
I think so. I mean, we've obviously, like you, we have a range of sort of clinical partners and things like that, and they consistently say that overall they've seen more change in the last year than they have done in the last 5 to 10, maybe even 10 or longer, as far as digital health is concerned. I think we've been impacted in a way, in the sense that, particularly within primary care and community care, the where we focus, for example, in our product with cardiovascular disease, is really on the screening, risk assessment end of things. We're actually pushing to now that those are the things that have been punted, as in they weren't important enough to do, and now they're causing huge backlogs and huge follow-on. So we're part of the kind of vanguard of trying to say, well, look, hold up a second, they definitely have to come back. And if you have a remote smartphone app-based solution to run the test, run the assessment in real time, upload the information to the GP primary care service, provide feedback in real time, which is sort of similar to where you guys come at it, that makes these things way more cost efficient, way more effective. And it means that you can actually do them, because if you don't do them, like you say, all you're doing is storing up downstream cost, which, that might be what you want to do right now, but at some point you have to pay the tab. And, so that's sort of where we've sort of found it. And I think what's been really interesting is talking to virtual GPs or telehealth providers, particularly some of the ones we had on the show. So we've had Push Doctor on the show, Dr. Care Anywhere, a few other people in that space, and they're all there's a point where at some point you have to touch the patient, right? So that near patient or at patient, whether it's diagnostic or monitoring or whatever it happens to be, at some point you have to be able to blend the virtual or the digital and interact with the patient. And that's sort of where we are from a purely blood-based diagnostic perspective, and you're coming at it from a different, the range of markers that you're monitoring. But I think that that's really going to be a critical point for some of the virtual telehealth people as they move onwards, because a lot of them at the moment, really, they can cope with the first appointment, virtually, and then they then really at the moment have to send people to a secondary care service, which is fine, but you're then back in the same process that you were in before.
Absolutely.
So then I think that space is really interesting about about things that started off completely virtually, but then we're now, things had to be virtual for 13 months. Got it, fine. But now we have to get back to a point, but it has to be a blend, I think. And I think stuff that manages that blend, I think is really interesting, because if it's just, call it analog or, app patient, then that's not really scalable. But if it's just virtual, then that has limitations.
Yeah, absolutely. Couldn't agree more.
Cool. Look at that. We're on the same page.
Yeah.
That's good. So I know you touched on it a little bit, but one of the things that I found really interesting from our pre-show production call, which was around, because sometimes people, I know you're not in remote monitoring, but this sort of space of using digital health in a near patient manner to gather biomarker data, to gather information to provide to somebody to make a diagnosis, to get someone on a treatment path. What you were talking about before is there is the unknown risk or risks that are associated with that. So could you explain a bit more about that? Because I know that people talk about this, like you said, just get a pulse oximeter and measure your pulse and send it into your GP, and like, why don't we do that? So why can't you do that? Or why shouldn't you do that? What are the risks in this area that people don't realize?
Yeah, I mean, that conversation is very kind of closely coupled with the one around accuracy and reliability that we were having a bit earlier in the conversation, where, what is the risk of a clinician making a decision of the wrong set of information, which inevitably could happen if, as we said, if you have a sensor into the hands of a not so well trained or not clinically trained user. This could take various kind of shapes and forms. It could be delay in diagnosis, which then leads to exacerbations and eventually kind of a much more expensive and complicated ways of treating people. And I gave an example with pneumonia earlier.
Yeah.
But it could also be kind of more recurrent issues that have to do with treatment management of chronic conditions like the space you guys are in, with, let's say, cardiovascular disease. Like the importance of the primary care physician having extremely reliable data that they then use to personalize treatment at the back of is really fundamental.
Yeah.
And that's the conversation that we really should be having right now. It's exactly what you're saying. Like, granted, over the last 14 months, we had to be very reactive, and we had to digitize and virtualize the bare bones of healthcare as much as possible to get through the crisis. But what is this blended model that allows us to preserve as much of the kind of precision of healthcare that clinicians are capable of, and merge that with kind of the scalability of technology?
Yeah, I completely agree. I think to the point around the risks, I think sometimes people don't necessarily realize, like, for example, if you use your digital stethoscope wrongly, for example, if you apply it wrongly, that could be the single best piece of kit in the world, bar none. But if it's put on the person wrong, it's effectively useless. So, and I think that there's definitely a tendency to kind of, like, I don't know, obsess about how good the device is and just assume that someone can use it and will use it consistently in the right way, when actually, as you know, and that's the reason why you've developed your AI platform to manage that just fundamentally isn't the case. I think one of it's not specifically a digital issue, but the COVID-19 antigen rapid tests that are CE marked for use in a professional setting, but drop, and in a clinical, highly regulated setting, have a certain level of accuracy, but the accuracy level, if you do it on yourself, or if the healthcare professional doesn't do it properly, it drops to, effectively useless as a diagnostic tool.
Yeah. I mean, and to be honest, you could simplify these examples for yourself to kind of realize how trivial it is. It's almost like assuming that you can make the best scalpel possible, but that's not going to make me a surgeon.
No, right. Yeah, no, exactly. No, it's
you could overinvest into the scalpel as much as you want, but it's not going to compensate for the fact that I don't have the skill set to be conducting a surgical procedure.
I think that's a great example. And yeah, I definitely wouldn't want to be the one using the scalpel. That's not going to go very well. So how do you see, what's next for Feebris in the next 12, 18 months? What's on the docket?
Yeah, we have many exciting projects we are working on at the moment. I mean, the care homes and just the elderly patient group in general remain a strong focus of ours. A few other things we're looking at the moment is really focusing on workforce models, emerging workforce models. And that's really interesting to see how that plays out in the UK, but also we're seeing a few very interesting examples from the US that we're currently figuring out how we tap into. Especially in kind of the bracket of healthcare visitors.
Okay.
So people that act as an extension of primary care in particular, who are equipped with the tools and technology to come into your home, conduct an examination, save the GP a lot of time in having to do that themselves, or in you having to visit the GP practice and overload them, which currently we can't possibly afford to do.
Yeah.
So that's definitely a big area of focus for us. We are also working on kind of continuing to evolve our R&D efforts in the pediatric space. As I mentioned before, historically we've worked extensively on this in India. Over the last year, there has been a lot of kind of stop and restart there as a result of the various lockdowns they've experienced. But we're still strongly committed to the pediatric space, and we hope to bring that to the UK as well over the next few months. And fundamentally, what we are kind of growing up to be is a workforce solution for delivery of early diagnosis that's most appropriate for the super utilizers of healthcare. So that's the top 5% of patients that cost 50% of the budgets.
Right.
And typically that's elderly people and young children.
Okay. Is it really young children as well as some of the super users or utilizers?
Specifically like young children with very complex needs. So the premature neonates, for example, that they have to go in and out of hospital quite frequently.
Okay. And we, a few weeks, actually near the start of when we started doing the show, we had Adam Hunter from Flow on Digital Pharmacy. I had a really interesting conversation with him about how he saw the evolution of pharmacies, particularly community pharmacies. And is that I think there's a role for community pharmacies to deliver more assessment-based, near patient sort of work. Is that something that you guys have thought about at all out of interest?
Absolutely. Yeah, absolutely. I mean, for us, we see this, and that's why I keep saying that we see ourselves as a workforce enablement tool, because we see a network of non-clinical professionals that we can activate in various clinical situations to absorb a lot of the burden from primary care. And that could be pharmacists, exactly as you're saying. In fact, they can unlock even more kind of actionable patient pathways than a carer could, for example. But it's the social care workforce, is these new emerging models of healthcare visitors. The combination of those, from our perspective, it's the future of healthcare delivery in a country and in a world that's massively under-resourced when it comes to doctors and nurses.
Well, I think that is a great statement to end the show on. You know, I think that's a good one, just to say thank you very much for coming on the show. It's almost like we planned. It's almost like we planned that. Thank you very much, Elina, for coming on the show.
Lovely to speak to you.
Yeah, and thanks to everyone for listening, and we'll come back next week with another show. So yeah, thank you very much, everyone.